Welcome everyone to day 3 of NaRCAD 2022. It's our final day. We're going to be going out with a bang today with some really great programming. Anna and myself will go through our usual morning to-do list, and it will be nice and brief. For those of you who have joined us on the previous 2 days, feel free to feel like professionals knowing which slides are coming next. Just a reminder, this is our 10th conference. We've been feeling really great about how it's been going. And we've been really appreciative of those of you who have filled out our evaluations for days 1 and 2. There will be, of course, a final one at the end of the day. So please stick around for that. And if you haven't had a chance to do days 1 and 2, we'd be so grateful for you to be able to fill those out. And actually, Anshul, I would love if you wouldn't mind popping that in the chat box now for those folks who know the housekeeping like the back of their hand and might be able to take a moment to fill out our very brief but very helpful surveys. So thank you for that. Anna, over to you to kick us through housekeeping.
Yes, welcome to day 3, everyone. We are in for an absolutely amazing final day. So we will run through housekeeping briefly, and this will be a refresh for many of you. Please turn your video on so we can all see you and interact with each other. If you'd like to have your view on your Zoom and speaker view, that would be lovely. So you can have the presenter speaking and the slides right next to each other. Please keep yourself muted when you aren't speaking. And please make sure that your name is correct on your Zoom screen with your pronouns listed if you're comfortable, so we know what to call you. And next slide, please. We will be staying on time throughout the conference to give all speakers their allotted time to present and each presenter time for Q&A. As we've done for the past 2 days, please continue to use the chat box, share ideas, insights, links, and tools in there. Please remember to keep any patient stories you share throughout the conference anonymous. We'll automatically add you to our mailing list. If you'd like to opt out, please let Anshul know by Friday. And finally, please reach out to Anshul if you need any technical support today.
Thanks all. And just a reminder for those of you who are unable to put your cameras on at the moment or perhaps throughout the day, it is of course optional. It's just a pie in the sky hope for us that we can see your face. But of course, do take care of what you need to do and join us as much as you are able to. All right, Anna, let's talk about what's happening today.
Yes, here we go. So after our kickoff, we will be joined by Carla Foster, who will present on an anti-racist healthcare campaign that is being developed in New York City. Then we'll have a plenary where we'll hear from several of the Veterans Health Administration's academic detailing projects. We'll have a break, and then we'll hear reflections from successful AD programs in our 2022 yearbook session. We'll then have another break before heading into our networking portion of the conference, where we'll host a virtual roundtable to get you ready for the year ahead. We'll wrap up day 3 with reflections and closing remarks.
Excellent. We're looking forward to seeing you at as many of these sessions as you can join. And please do join us for our real-time roundtable. Anna and myself, as well as Anshul and Mike, and Jerry as well, I'm sure, are really looking forward to hearing about what you want to do in 2023. We certainly love to cater the menu to whatever it is you are hungry for. So with that in mind, we have been really excited to bring you something new that Anna and Anshul will be talking to you about. And this was informed by your need for this information. So just an example of the ways that we love to focus our programming on what it is you ask for. Anna and Anshul, over to you.
Yes, we have something very exciting to tell you all about. I will try my best to contain my excitement, but our team has been working on developing a toolkit on healthcare inclusivity based on feedback from all of you. You told us that you need support when talking to colleagues, clinicians, and even friends and family about stigma and bias. So Anshul has led the charge and put together a terrific resource, which we are proud and excited to officially launch today. And I am going to hand it over to Anshul to share a few words about the toolkit, and then we'll walk you through some specific pieces of it in just a moment. Anshul, take it away.
Thanks, Anna. And I just dropped the toolkit link in the chat box if you're curious to see really quickly what we have in store. But yeah, as both Anna and Bevan mentioned, thanks so much for to our community for inspiring this toolkit, as well as I should also give a shout out to my predecessor in this role, Winnie Ho. She also helped inspire this as well at NaRCAD. But our toolkit here, it's just a starting point. So we're hoping to continue to grow and add resources here to help inform your needs in healthcare settings. So if you have any suggestions or anything that you're seeing in this toolkit that you would like to see more of, definitely let us know. But I'll go over more about what exactly we have in this toolkit in a moment.
Yay, thank you, Anshul, for all your hard work to make this toolkit come to life. So why do this now? Why did we make this toolkit? Clinicians often have stigma, and detailers have told us that they are uncomfortable, they're caught off guard, they're angry, they're shocked and defensive when clinicians or colleagues use stigmatizing language. As much as we're frustrated when these situations come up, we want to make sure that we understand stigma as a detailer so that we can support clinicians in behavior change. No matter the reaction that we may have or that we may want to have, we all need additional support around this topic. And Bevan, how have we at NaRCAD been able to help with that?
Well, our role has been to make intentional space for our community to really chat about what's been bothering them. Not only has it been, at least from what we've been hearing from folks on the ground, uncomfortable for you all as detailers to walk into some one-on-one sessions and be caught off guard by comments that can range anywhere from more subtle types of expressed stigma towards clinicians, patients, or a specific disease or issue, especially around things like obesity, diabetes, things like smoking, other use disorders, and so on. We've also needed to consider that we all have biases. And so part of our inclusivity toolkit involves some great materials Anshul has curated around exploring our own implicit biases so that we can then not only understand ourselves as humans, but go into those clinicians' offices feeling the ability to exercise empathy as much as possible and ask about storytelling. So our job here is to make intentional space for you all to come together in peer settings, such as our roundtables and our quarterly check-ins, to discuss these issues, discuss our own discomfort with some of these issues, and also try to find ways that don't solve the entire realm of stigma, which is impossible, but allow us as a community to come up with tools, whether they be scripting tools and so forth, to communicate with clinicians in a way that really does not put them on the defense or judge them as well. And so we'll be continuing to provide resources and allow you to connect with each other so you can feel more empowered versus stuck in sort of a potential fight, flight, freeze, or fawn, sort of state. And we will be, as Anshul mentioned, turning to you, since you are the ones on the ground, to tell us, gee, in that moment where I froze completely, I wish I had had X. Or in that moment, I don't know what I would have needed. So that, let's say Janice is in the room or Lexi's in the room, they might be able to say, hey, I think it would have been helpful for me in that situation to have Y, or our organization has considered starting to implement X. So again, we're looking at you to figure out what the Y and the X are. We have our own creative ideas, but again, you are the ones on the ground, and we want to make sure that you have a sense of things you can apply realistically. Again, we're not going in as anti-stigma superheroes. We can have that goal at mind, But again, we want to make sure you can approach these things realistically and with our support, and come back and say, hey, I tried this tool and it really worked, or I tried this tool and it completely bombed. So again, this is a working community. We really want to have a community of practice around this. So I'm going to turn it back to Anshul to talk a little bit more about what's in the toolkit. And she did say, if you want to take a look at it real quick, you can, but I do believe she's being modest. Take your time when you have a moment to explore this in depth. So let's talk in an overarching way, Anshul, about what's in this toolkit.
Sure, thanks, Bevan. So in our toolkit right now, we've split it up into 2 bucket areas. So on the left, we have a button for getting started. We have educational tools and materials related to implicit bias, cultural humility, communication strategies, as well as best practices from our community. So folks that have provided webinars or blog posts here at NaRCAD, we've also shared their thoughts and expertise on this topic. And then to the right, we have resources on clinical topic specific. So if you'd like to dive in deeper to specific stigma related to substance use disorders, HIV prevention, and mental health. And then in the next slide, we just show kind of how it's split up into the separate pages. So again, in the educational tools and materials section, we have video resources, publications, articles, all in these 4 bucket areas. And also, again, to mention that in these pages, we also have a section for you all to share your feedback on any resources that worked really well, or maybe you would like to see more of. So those will directly get sent to our NaRCAD inbox. So that way we can continue to grow and build this toolkit. And then here, this is how our clinical topic specific resource section is split up, and also explores resources, videos, and publications on these 3 bucket areas.
I love this, Anshul. And of course, these are not the only 3 bucket areas that stigma exists within. So we're looking forward to fleshing these out. Again, there are so many areas. Start thinking about the work you're doing. And of course, you know, stigma you may have come up against when you as a patient go in to talk about certain challenges and you know, health related conditions you may have. So again, we want you to help us inform this work. We'll be kicking this off more officially into 2023, but the soft launch is via the link that Anshul has popped into the chat box. We are so excited to explore. And again, this is just the beginning. So thank you to all of you over time for talking to us about this. All right, Anna, it's poll everywhere for day 3. Let's get people set up to do our last day of this and get over to their cell phones. If you want to walk them through it one more time.
Yes, take your phone out and text the number 37607 with the word NaRCAD 1108. And once you do that, you will be entered into the room and you should receive a message that you have been accepted into our chat room.
And as we move forward, if you're missing this content on this slide, fear not, Anshul has popped it into the chat box. All right, so here is our first poll of the day. It's a juicy one. In any setting, what's your reaction when you hear a stigmatizing comment? Okay, here's our first one, gasp. Yes, yes. What else? Discomfort. Of course, this is not something we necessarily feel comfortable hearing. Interesting. That's a good one. An observational curiosity. Cringe, feeling offended. Again, another cringe. Let's take a couple more before we move on to our next poll and introduce a very relevant presentation from Carla Foster in New York City. Pause, I'm done with you, I'm frozen. Mild recoil, ooh, that makes me think of a snake just coiling up. Taking a deep breath, more freezing. So I'm not noticing anything that feels sort of positive and able to be armed to deal with this. Anxiety, my face, I'm upset. Yes, this all tracks with some work we've done with focus groups related to stigma, where we've asked detailers what it is they've come up against: concern, extremes of freeze or fight, and a few more of the same things: being nervous, discomfort, being silent, and getting out of there. All right, Anna, here's our last poll before we introduce Carla.
All right, why might people have stigma towards vulnerable populations?
So let's think about why any of us, but especially the clinicians we're meeting one-to-one, might have that stigma. Anna, let's go back and forth here. What are you seeing?
Sure, I think the ready with a comment was for the other poll, but past experience, I love that one to start us off. Go ahead, Bevan.
Ignorance, of course. Where's the info on what these populations need? What else are we seeing here?
I'm seeing some more for personal experience, fear, negative experience, preconceived notions, the unknown.
Yes, lack of experience. These might be populations we haven't met as clinicians. Another one for ignorance, insecurities, and past experiences could be times that clinicians have interacted with certain populations, but it could also be things we learned from our families, things we learned growing up. And again, prejudice, racism, fake news. Yep, you got it. So let's move on and get on over to a presentation that I know our home team is particularly excited to learn about. Thanks, everyone. Feel free to keep these answers going in the chat box. I am so delighted to introduce Carla Foster. She's become a big part of our community. We have a special presentation today looking inward, academic detailing as an intervention for anti-racist healthcare. We've come such a long way with our programming here and finding ways to really look at things that have worked. Carla and the New York City team have really made strides in the past years to figure out ways to look at bias, to talk to clinicians about their patients who use illicit drugs, how to support them without judgment. And so I will back right out of the way and introduce an amazing epidemiologist from the Healthcare Provider Initiatives Unit at the New York City Department of Health and Mental Hygiene. Welcome, Carla.
Good morning, everyone, and thank you so much for that warm introduction. I just want to start off by saying I'm so excited for this toolkit, and I can't wait to go through it. And I'm just as thrilled to be here today to discuss the concept of detailing as a mechanism to advance anti-racist healthcare, and to share my experiences conceptualizing and developing what we anticipate will be the nation's first public health detailing campaign on racism and healthcare. And I want to take the time before we delve into the presentation to acknowledge how the exploration of racism and white supremacy within the world, the nation, and indeed within ourselves is not an easy one. Just the words racism and white supremacy can elicit uncomfortable feelings and emotions for many, if not all of us. And one of my aims for this presentation is to highlight how racism and white supremacy impact us all, regardless of racial or ethnic background or even socioeconomic status. And white supremacy is insidious. And I would posit that it is impossible to grow up in a nation with a foundation and culture of racism and not be impacted. Indeed, because of the inherent universality of racism, tackling this issue is one that requires a broad coalition, and everyone, regardless of background, benefits from living within an anti-racist society. Next slide, please. Here's my disclosure statement indicating that I have no relevant financial or non-financial relationships to disclose. So I lead public health detailing, as Bevan mentioned, for the New York City Department of Health and Mental Hygiene's Healthcare Provider Initiatives Unit, also known as HCPIU. We focus on the development, implementation, and evaluation of citywide public health detailing campaigns, typically reaching more than 1,000 healthcare providers per campaign. Our program also serves to mentor detailing programs across the nation, and we welcome the opportunity to exchange experiences, successes, and lessons learned with our detailing colleagues. The health department has long positioned itself as a leader in producing public health detailing campaigns, as well as exploring topics that often go unheard, such as stigma. In October of 2021, the New York City Board of Health passed a resolution declaring racism a public health crisis. And this declaration really served to further prioritize the health department's commitment to advancing anti-racist healthcare. Next slide, please. And so, as we have established, racism is a public health crisis within New York City, as well as within the United States. And experiencing racism seriously impacts physical and mental health. And it does that by increasing allostatic loads, also known as weathering. The chronic stress, as well as inflammation, increase risk of ailments such as anxiety, substance use, dementia, and cardiovascular disease, among others. So racism has a very real health consequence, and not just for people targeted by it. While less research, peer-reviewed studies on the topic show that those perpetuating racism also face increased risks to their physical as well as mental health. Research published within the Journal of Social Issues indicates that harboring racist feelings causes a daily stress. And this kind of stress can lead to chronic problems such as hypertension and type 2 diabetes. In fact, a recent study published in the American Journal of Public Health found that all people, regardless of race, living in communities with high levels of racial prejudice were more likely to die young than people living in more tolerant places. And this higher mortality was evident even after controlling for individual as well as community level socioeconomic status, such as poverty, level of education, and racial composition. So as part of New York City's response to this public health crisis, we are in development on a public health detailing campaign, which, while focusing on the impacts of experiencing racism on health, will also cover the impacts on those perpetuating racism and how healthcare providers can, and we would suggest should, play a role with eliminating erroneous and dangerous race-based care. Next slide, please. So as you might imagine, the journey to developing this campaign has not been easy. When I first recommended a public health detailing campaign on the impact of racism on health and healthcare in 2017, I received quite a bit of pushback from some of those in leadership who felt reluctant to engage in this often overlooked and what some would consider controversial topic. Next slide, please. However, we were not deterred. We pursued a strategy of conveying the universality of racism and white supremacy, so that essentially we are all negatively impacted by white supremacy, and thus we all serve to benefit from developing an anti-racist society. And this strategy allowed us to gain health department support from leadership, to secure funding, as well as establish panels consisting of external as well as internal collaborators. And essential to this strategy were developing literature reviews and a document known as a city health information on the topic. And the key ingredient to our success, however, I need to point out, was perseverance. While we did not anticipate a 5-year journey to campaign development or many of the roadblocks that we face along the way, our team's unwavering commitment to this critically important detailing campaign is ultimately what led us to success. And I want to take a moment to encourage anyone pursuing challenging topics within detailing to simply not give up. Perhaps your strategy needs to be reworked, or you need supplemental expertise from external stakeholders, or your communication techniques require revamping. But with perseverance, success is possible. Next slide, please. So moving on to 2020, our campaign faced another hurdle when development was paused due to the health department's COVID-19 emergency activation. However, in 2021, we were able to resume development and at this point acquired additional leadership support as a result of the heightened focus on racism subsequent to the May 2020 murder of George Floyd. Next slide, please. As part of our campaign development, we conducted qualitative interviews with healthcare providers to assess knowledge and current practices related to the impact of racism on health and desired tools and resources to address this crisis. Yes, next slide, please. Shown here are some of our research questions, including, are healthcare providers aware of the impact of experiencing racism on health? Do healthcare providers assess patients for experiences with racism as well as the associated chronic stress? And what materials and resources are most useful to healthcare providers to empower them to address the impact of racism on health with their patients? So recruitment for the qualitative interviews were based on previous health department program involvement, as well as snowball sampling. We set criteria for eligibility, including at least 2 years of clinical experience, with that experience being with direct patient care within the US. We conducted interviews both via phone as well as in person, and we administered assessment questions on participant awareness of the impact of racism on health, as well as desired tools and resources for addressing this impact. And we also conducted thematic analysis. Next slide, please. For the 19 participants in our qualitative study, they represent a variety of specialties, as you can see here, and practice in hospitals, community clinics, as well as academic settings. The portion of self-reported racial and ethnic identity for participants very closely tracks with that of healthcare providers within the United States. Next slide, please. Getting into some of our responses, we were extremely encouraged that all participants acknowledge how deeply intertwined racism and healthcare are, and most were motivated to act upon this. However, nearly all participants also reported a total lack of the tools and support to do so, including needs for screening tools, misbusting literature, as well as a real desire for personal cases to highlight the impact of racism on health. Next slide, please. Participants in this qualitative study reported desiring information on how to initiate conversations, including recommended language and phrasing, information on avoiding a savior atmosphere, also known as neo-colonialism, by highlighting the benefits to healthcare providers themselves, practice guidelines on dealing with race within clinical algorithms, and participants expressed a clear preference for access to online resources, as well as easily accessible one-pages or pocket guides that they could either keep on their person or within a high visibility area within their practice. Participants also reported appreciating this information gathering portion of the campaign and felt that it highlighted the "we're in this together" sentiment that the campaign seeks to portray. Next slide, please.
All right, we have a poll here. How would addressing white supremacy and promoting anti-racist practices benefit your professional relationships? You can think about your relationships with clinicians as you approach detailing them. You can think about your interprofessional relationships with colleagues, supervisors, etc. So let's take a moment and pop on over to your phones or the chat box and see what's on your minds about how these approaches will help or benefit your relationships. All right, it'll improve awareness. Patients would get better outcomes. Yes, fewer barriers, building trust and a sense of community, enhancing patient care, creating safer spaces for more people, more collaboration, and more of a sense of an openness of communication. That's pushing past that discomfort, that sense of we don't want to touch this, building trust with patients themselves, engaging community champions, again, increased respect, collaboration, more on the community trust, and opportunities, again, for these frank, open conversations that will improve psychological safety and openness. I love these answers. And again, reflecting on ourselves, being better informed, and again, thinking about how we can apply this. I like this comment too that talks about the struggles. There are so many who don't believe that anti-racism occurs, especially in the South. I'm sure that's someone who, works and lives down there. Re-engage providers on why they're doing what they're doing. Yes, this could possibly decrease stress and then related burnout. And we'll take a couple more. I see increasing respect from Takesha in the chat box. And again, a lot of things around here about engagement, collaboration, respect, openness, access. And then someone who says, I'm really not sure. Carla, I'm going to turn it back to you. Do these answers seem to connect with the work you've done, or any of them surprising?
Definitely. And thank you all for these very thoughtful comments to this question. And a lot of the things that have come in from all of you really highlight not just the benefits to healthcare providers and to yourselves in terms of advancing anti-racist healthcare as well as general practices. It really goes to show that we all have a role to play within addressing this issue. And I think that all of your responses also show that if we can come together and work on this together, it's a lot easier to engage people on what, can be a challenging topic. And I think, this holds true not just for talking about racism and white supremacy, but also for issues of stigma. And a lot of issues that get into the toolkit that just came out. So I really think it's a great thought experiment to think about how we ourselves can benefit, our work, and the people that we work with can benefit from beginning to take on this work. And so moving on, we had similarly thoughtful responses from the participants in our qualitative interviews. One participant noted that race skews clinical algorithms, indicating whether a patient could be at high risk. And that participant stated that, I'm not going to sign on to that until you show me there are no racial implications in both the data and how it plays out. I am fortunate to be in a position to catch that and be cautious about that. Not to mention how racism affects the way we take care of patients and the death rates. It is all over the place. Next slide, please. A participant responding to the question about mitigating the impact of racism on health said, "This is less often discussed. Perhaps I should take more opportunities to talk about it when there is a chance. For example, I have a patient who is part Japanese, part Jamaican, and is a woman. She gets it from three ends. She gets racist comments from how people view her dark skin. Then she gets comments like, oh, you're Asian, you guys caused COVID. And she is a woman, so it seems no one listens to her as a result of sexism. And these color her experiences and her outlook, and her experiences in society are like trauma. It affects her psyche and her health, as it will raise her cortisol levels and other stress hormones that have negative effects on her health. She always has to activate her sympathetic nervous system and always has to worry and be anxious, not knowing if something is going to happen. I recommended that she maintain her exercise routine and to consider tools such as meditation. I would love to have a pamphlet or other item to give patients about this. People do not want to talk about this unless someone else initiates it, and that suppression affects the next generation." And I just want to take a moment to highlight how this is an issue, again, that is passed on, and how the impacts on health will affect everyone, regardless of race, regardless of ethnicity, and will affect you, from the time that you're born until the time that you pass. So I think it's really important that we begin to think about how to have these challenging conversations in a way that is engaging to people. Next slide, please. This respondent highlighted the theme of a broad coalition to address white supremacy, stating, "One thing that perplexed me is how to make everything not sound so serious. Humor may not be the right way, but we can do this. We are in this together," that kind of approach. A togetherness, something that brings people together. That should be a key part of the message. Next slide, please. So togetherness or collaboration must be at the core of any successful detailing project. And we consider the three pillars of collaboration as those providing detailing expertise, such as structuring content into actionable form, creating materials that are suited to ease of use, ensuring broad dissemination of key campaign recommendations and messaging, implementing and managing detailing campaign and field work, conducting campaign evaluation, as well as disseminating results. And for those with subject matter expertise, they can contribute with assisting with identifying main topics to address, assisting in drafting of key recommendations, and validating content for accuracy. Those who bring community or peer expertise are critically important to ensuring inclusion of the community's unique needs, values, priorities, and preferences, and assisting in the review of drafted provider and patient materials. So detailing expertise, subject matter expertise, as well as community expertise are each essential to creating a successful detailing campaign. Next slide, please. For this detailing campaign, with the purpose of increasing awareness of the impact of racism on health outcomes and promoting health equity within New York City, our goals are to educate healthcare providers and patients on how experiencing racism impacts physical and mental health, to support healthcare sites on acknowledging that exposure to racism has devastating biological and health consequences, and to provide opportunities to advance health equity, to promote communication best practices, to actively and empathetically engage patients who have been negatively impacted by racism, as well as to end the inclusion of race adjustments and race norming within clinical algorithms. Next slide, please. As we began to develop the key recommendations for this campaign, we use the criteria stated here as a guide to ensure that the key recommendations reflected our overall goals for the campaign. As most of you are well aware, the key recommendations form the backbone for any detailing campaign. And so it is critically important to have strong recommendations to create a strong detailing foundation. Next slide, please. The focus of our key recommendations are listed here and detail how white supremacy and racism impact health, normalizing the discussion of racism and associated physical and mental health outcomes, and how race adjustments in clinical algorithms can guide poor decision-making. The materials contained within the campaign action kit will support and further expand upon these developed key recommendations and draw from responses received during the qualitative interviews. And I want to point out that while this topic is far-reaching and tackling racism and white supremacy can feel overwhelming, we believe that this campaign will provide a step forward and hope that other jurisdictions will consider detailing on this topic as well, as how to address racism and white supremacy within all of their detailing projects, regardless of topic, and really sort of being able to weave that into your work so that it is something that is seamless. And I think that that continues to move forward the idea of normalizing discussions of race, of racism rather, and of white supremacy. Next slide, please. And I just wanted to lastly take a moment to commend NaRCAD for consistently serving as a vanguard for topics that are overlooked or even intentionally ignored. Your commitment to advancing health through detailing practices is really not bound by traditional or even current limitations. And I think that this creates a beneficial feedback loop between NaRCAD and those like myself who benefit from NaRCAD's expertise and contribute to the idea of seeing the world not just as it is, but as it can be. So thank you all, and I'd like to now open it up for any questions, comments, or general discussion.
Thank you so much, Carla. This has been, breaking new ground, for us as a detailing community. And we're really excited to have some questions from the audience. And so we do have a comment, that was sent just to me, but I think I know the answer. Once this program and materials go live, can we just kind of borrow some for our site to share with folks, if that's okay? I'm pretty sure I already know that the answer is yes from Anna, but I just wanted to make sure because people are asking me.
Yes, the answer is absolutely yes. And I think that is extremely flattering to hear that. So thank you for that comment. I would just ask that you reach out to us and to include the little New York City Health logo, even if you change the colors or something like that. The health department would not appreciate it if I did not mention that part.
We will keep things just as they are, but I'm getting a lot of enthusiasm here to just kind of, you all are such thought leaders in the field. And of course, New York City is its own unique being. And so, we understand too that, your dialogue with the city and allowing that to sort of lead the charge as well is something that may be difficult to apply to other more homogeneous areas. But I think just the fact that you're diving into this, I see comments in the chat box about not learning even the basics about systemic racism. We had a comment earlier in our poll about folks not even believing that it exists because it's not seen in an overt way. I'm wondering if you had any suggestions or ideas, especially informed by your campaign, about how to begin those conversations if clinicians in other areas or even in New York don't see it as a major issue. Think of white supremacy as being far less subtle and more something of years past, and thinking very much about overt, white supremacy being neo-Nazism or, the KKK. How do you go about looking at this sort of interwoven and insidious pieces of white supremacy? If you were to suggest ways to speak about it, that's a huge question that I'm throwing at you, but just some thoughts would be helpful.
Yeah, and I think that's a really valid question, especially as you said, within areas where people, this is something that is not on their radar at all. And I think that key to this, from our experience, is going into some historical background, laying out what exactly white supremacy is, and how it has impacted people regardless of racial or ethnic background through the years. And I think that establishing the universality of how people are impacted by white supremacy, and indicating how perhaps that person themselves has been impacted. And I think with that historical knowledge and historical background, then you can proceed to get into the idea of looking at how racism, not race, is responsible for health disparities. I think that there is no denying the fact that health disparities exist. These are data that, have been well researched and well established. And if we can present research, which, also exists, there are many, many studies indicating that even when controlling for socioeconomic status, for education, for all sorts of different characteristics that you think would impact health, Black people in particular have worse health and health outcomes than the majority group, white people within the United States. And so looking into that, I think begins to lay the foundation for what I mentioned, that racism, not race, is responsible for poor health and health outcomes. I think looking into the biological impacts of experiencing racism on health, looking into how high allostatic loads and how weathering impacts health, being under chronic stress every day for your entire life, how that impacts your health. I think that is really something that sort of takes away the issue of whether or not do, these phrases or words, racism or white supremacy, exist, but here is a real problem. And how can we address this problem? And I also think that really centralizing that we are all trying to work together to improve health for everyone. And I think some people might be surprised, to hear that those perpetuating racism are also impacted, their health is also impacted negatively. And the fact that just living within a community that has high rates of racial prejudice, regardless of your racial or ethnic background, is something that impacts your health negatively. And so I think that's a real point to begin a discussion, to say that, we're laying out this real problem. Here are the data to back that problem up, and we're working on solutions for this problem.
Okay.
And
Yeah.
we have, yeah,
Oh,
I think
sorry,
we have had great engagement. Yeah, just with this strategy.
That's excellent, because this can be so overwhelming for someone who's just never thought of this, especially the fact that many of our detailers are white. And so looking at this concept, I'm kind of distilling some nuggets down from this, if you may allow me to do that without hopefully it seeming that, we're taking away the context, but going into these sort of three pieces to start a conversation that racism, not race, is responsible for poor health outcomes. Racism affects all races, impacting even those who are racist, right? So if you're speaking to somebody who represents the majority, making it about them can also start a dialogue, even though we hope it doesn't have to be that way. And then evidence, 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 right? Bring that evidence. That's the cornerstone of AD. So it becomes less of a social debate and more of a debate, or hopefully not a debate, of bringing that evidence with, proper citations, starting slow because behavior change is tricky. But again, these seem to be the distilled nuggets that might start a conversation. And so I love that. One thing I also love is not a lot of questions in the chat box, but plenty of reflections about how important this is, how it's going to influence so many folks in the audience and their future work. I do have one secret question from Dr. Fisher. I'm going to read this aloud. So Carla, you mentioned that your leadership was initially concerned about this campaign due to potential controversy. And Mike says that he saw that one of your citations was from Dr. Michelle Morse, your colleague who used to work here in Boston. He said that when she and colleagues worked on racial inequity in cardiovascular care and proposed a restorative justice intervention, it was caricatured in the media in some ways that were perceived as being in bad faith. How do you prepare for those arguments and avoid getting pulled into sort of trolling style arguments, so as to keep the focus on important areas for improvement? And how should people on this call think about this challenge when making the case to their organizations who may be risk averse about the importance of getting involved? That's a big question, but might as well wrap up big.
That's an excellent question. I think something that was key to this project are the qualitative interviews that we conducted with healthcare providers. This is something that we had never done before for any of our detailing campaigns, but again, this is a topic that we have never done before, and a topic that, as I mentioned, took a good 5 years and counting for us to even begin to get into the meat of the development process. And so these qualitative interviews with healthcare providers, they serve not only to allow us to begin to have partnerships with healthcare providers as well as the sites where they work, but also to show our leadership, look at these responses that we are getting. These are healthcare providers themselves who are saying that we are noticing this issue within our practice and we don't know what to do about it. And I think that it sounds simple, and it's a very concise way of putting things, but I think that's really profound. I think in what other area do you hear a healthcare provider saying, I'm having patients come in and they are dealing with this issue that's impacting their health, and I don't have the tools or the resources to assist them. And it's something that is really not ever addressed within healthcare itself. And that really got leadership to start thinking differently about the importance of this detailing campaign. And that sort of got the ball rolling in terms of being able to have champions within the health department, as well as with the people who we partnered with who are not within the health department. So we've been able to increase our engagement with collaborators across the country. And specifically, this detailing campaign will be within New York City, hitting all 5 boroughs. And for our New York City based collaborators, we've been able to establish deeper relationships with the hospitals, the clinics that they work at, so that when we do come, into their sites, we are able to have the leadership on our side stating that this detailing campaign is going to happen, and we encourage for you to engage with the public health detailing representatives on this critically important topic. So I think doing a lot of groundwork when you're dealing with what can be a very challenging topic is really something that will only benefit you in the end. In terms of pushback, I think the only thing that you can do is, first of all, expect pushback, back up all of your work with evidence as you pointed out, and craft your responses. I think, one of the key points of each of our detailing campaigns is thinking through the barriers that might come up during the detailing visit. And I think thinking of barriers that might come up just within the press or within the general community as well is something that's very important. We are planning a simultaneous media campaign around this topic that will have ads throughout New York City. So I think that, you know, we've already started thinking about what some of the responses might be to this media campaign and how we can address it. So I think preparation is really key just in terms of being able to create this campaign, but also being realistic about where we are and how some people might feel. And I think that keeping in mind that, you know, we or our detailing campaign or even many detailing campaigns is not going to solve this issue. But I think that when you're able to, you know, contribute a portion to moving forward the idea of anti-racist healthcare, whether at the very moment that you implement your campaign, regardless of how it's received at that time, I think that if you have a sturdy and strong campaign, I think that it will stand the test of time and be something that people are able to come back to and able to reference and able to use to develop future detailing campaigns, which hopefully will go far beyond anything that we are currently able to do.
Amazing. I've been trying to capture all these nuggets in the chat. Thank you so much, Carla. I know we've run a little bit over, but it really felt critical with this just really groundbreaking work. Folks, if you have continued questions or reflections for Carla, please do email us or direct message anyone on our team so we can triage them over to her now that we're wrapping up this session. I think I speak for everyone in thanking you for not just presenting something really groundbreaking, but helping us feel not like, oh, we could never do that. Your ability to translate and distill those nuggets and make us feel hopeful about the potential to have even a small impact versus saying, okay, I really want to fix all of this, because many of us are idealistic, right? And that's why we get into this kind of work. To know that fixing is not the way we want to go. Improving is the way we want to go. And that's why we're all in quality improvement. So thank you so much. We look forward to talking with you more, and we will certainly look to you and your team to continue to inspire us. Thank you. Thank you from all of us. Really appreciate you.
Appreciate you, and thank you.
Thank you, Carla. All right, up next, more than a service, we have a collection of AD programming within the VHA. I am excited to turn the mic to Mike and to introduce Melissa Christopher.
Yeah, thank you. Thank you for a wonderful kickoff to the day. And this is the excitement we'll keep up, because this is really getting a sense of what a fully realized version of our field can look like. So I'm really excited to be able to introduce our first speaker. The US VHA, the Veterans Health Administration, has been a leader in a lot of areas of US health. They're one of the first to have reliable electronic health records, to have a nationally integrated system, leaders in research and education. So it's really fitting that they've also been leaders and innovators in academic detailing. And a lot of the credit for that goes to our first speaker, Dr. Melissa Christopher. She's currently the National Director for the VA's academic detailing services. They reach clinicians in VA healthcare systems across the country. They've implemented nationally on a wide range of topics. They've been especially focused since 2016, since the Comprehensive Addiction and Recovery Act, on interventions through academic detailing to improve outcomes for the many veterans that they serve who struggled with opioid use disorder and other substance use disorders. They've reached over 20,000 individuals with their opioid safety education campaigns. Just as much as the impact of the program, Melissa's been a wonderful, long-standing, close colleague for all of us at NaRCAD. She's been involved in I didn't have a chance to go back and check whether every single one of our conferences, but I'm pretty sure, if not all, almost all. And it's been really determined. There are probably 3 or 4 people here who remember in one of our very first conferences when there was I think there might have been a government shutdown, and Melissa at the last minute couldn't get authorized to travel and had to present remotely way back before remote presentations were a thing, and flexed with that. She's brought wonderful new content to us. She and I went on the road a bunch of years ago to teach at a professional session about detailing, and we did a mock detail with each other. She's really been a wonderful friend and colleague to NaRCAD and to all of us in the community. And she and her colleagues, who we'll hear from over the next hour and change, have really done so much to move the field forward, innovating, evaluating, and publishing on their work, carrying through on what we talked about on Monday morning, on moving us forward as a field so we can understand how do we better accomplish our shared mission. So she's the ideal person to kick off this exciting session. Let me hand over the virtual podium to her now.
Thank you, Mike. That's a very kind introduction, and I have just really enjoyed every time we get to meet together here in NaRCAD. It's one of those times a year that our team gets reinvigorated by the work that NaRCAD is doing and the work that everybody in the field of academic detailing is bringing new innovations and new ideas. So I feel so blessed to be here and miss seeing everybody in person, because we always have a lot of fun together during our times in person as well. Boston's a beautiful place to meet up. I wanted to just begin by saying our 10-year journey with you. And when we look back and we celebrate our 10 years, our program actually started as a pilot almost 10 years ago. And now I think about where we have progressed from our early years of being in California and Nevada and the Pacific Islands, and being able to have a national program that actually reaches a larger portion of our VA providers and clinical staff, which has been a real blessing and testimony to the work that our folks in the field are accomplishing every day. So if we could go to the next slide, I wanted to introduce to you that this idea of rebranding academic detailing, I love that Bevan brought that up at the beginning of our meeting, because I feel like for 10 years, we've been trying to rebrand ourselves. And most recently, one of our executive board members said, well, really what I think academic detailers are, they're kind of like the special forces of our organization. They're doing special operations, and they're helping us with these very difficult to solve problems in healthcare to close the gap on the evidence. And so I wanted to kind of inspire you all that you are doing special forces work, and to think about the importance of how you're running behind the scenes, you're meeting one-on-one with providers, you're changing hearts and minds, you're changing organizations, and that without that work, you really can't win the objective of improving quality of healthcare, because you're an important tool in the solutions that we need in order to improve our systems for our patients. So next slide, please. Our VA Undersecretary for Health has come out with several priorities that help really guide what our academic detailing programs are focused on. And it's important to us to intersect at the highest level where our focus and where our priorities for campaigns, outreach, and interventions are. And so the three that I've highlighted here that really are at the forefront of the development of our programs in VA is accelerating our high reliability journey by providing knowledge translation services, connecting veteran to the soonest and best care. So the idea that we want to provide the best care everywhere, that's in rural locations, that's in every place that we deliver services, including as part of our Mission Act, how we deliver services in the community. So how do we impact the community care that we deliver with veterans as well? And then our third component is really preventing veteran suicide. And that's a high topic, high priority clinical topic area that we've, over the last decade, have really invested in a public health approach to impacting the lives lost by veteran suicide. Next slide, please. So after 10 years, there's some successes that I wanted to celebrate, many of which my team have been leading and really making sure that we cross the finish line in order to produce more innovation and more opportunities to change healthcare for veterans. The first that I'm excited to announce is that we are on kind of the tail end of establishing policy that requires academic detailing as part of the services that we provide. So we are working through our final approach and really establishing these services in every VISN. And this is to require knowledge translation services for VA clinicians. Some of the things that the COVID pandemic really taught us is how to provide a hybrid of services. So we went from being in person, printed material, knocking on people's door, waiting in the waiting rooms, to virtualizing our services and being able to connect with more providers, reach more locations through our e-detailing services. And now we're saying, well, how do we go back to some of our in-person stuff again? You know, what's the hybrid look like? How much do we provide in person? How much do we do as virtual? And what does follow-up look like? What are the transition to our service model as we experience a new normal coming out of our pandemic experience? The other element after 10 years is looking at the importance of not just providing knowledge translation, but also thinking about the barriers that we have in our healthcare systems and what process improvement support do clinicians need. That it's not just knowledge that we're providing, but it's also the execution of that information. How do you apply that knowledge in your practice, and what is in the way of you applying that knowledge? So doing more standardized training and work to really support the community of detailers with corporate knowledge sharing and providing a greater opportunity for them to resolve that for their providers. And as I mentioned, we also looked at how do you get best care everywhere? Well, you have to go everywhere. So that rural expansion is really critical. And also understanding the differences that clinicians are struggling with. What is different in your neighborhood? What do we need to understand about your practice and what's going on there in order for us to be able to support the change that is needed to deliver that care to our veterans? Next slide. So I wanted to just mention that medication safety is one of our top priorities for academic detailing. I'm so excited that Kimberly Dickerson is going to be talking to you a little bit about one of the most impactful outreaches that have been done on polypharmacy and trying to deprescribe unsafe medications for veterans. So it's great that she's going to be on our panel today. So we have done a ton of work nationally as a VA on deprescribing initiatives that has been around benzodiazepines for psychotropic drug safety. We've done a lot of work on opioids as the opioid epidemic really became a concern about pain management and appropriately prescribing medications for pain. But as we start to progress to see what other needs do we have to do knowledge translation for, we realize that there's lots of work to be done on therapeutic optimization. So a lot of our work moved into some of the topics that you'll hear from Gwen today, where as they're researching how do you change behavior in insomnia and other therapeutic areas to make sure the right evidence-based treatment is provided to clinicians. And then or provided to patients. And then new technology. When we think about innovations, the next generation of how do we apply pharmacogenomics in our decision models? How do we support providers with that information? So we're looking to the future to say decision-making includes new technologies, and how do we support our clinicians to adopt that into their decision-making approach? We've also realized that people are burned out, and we need to provide a survival guide for providers. So one of our top campaigns this year, which I was so excited to see, was really helping providers just navigate. How do I deal with these times? What is the pharmacy benefit? How do I get treatments to patients? How do I onboard a patient who's coming to me from another location? And that actually includes medication safety, because you're reconciling everything that the patient has been on and trying to understand what you're going to continue. So a lot of work with trying to orient new clinicians and even existing clinicians into the changing part of the healthcare system. So our provider guide has really been an important resource for individuals in this time. And then the final areas is really just addressing variability. And I want to emphasize that a lot of the topics about, looking at health inequities, looking at where we're seeing gaps even regionally across the country and not delivering healthcare, what do we need to do to change that? Those have been other opportunities that we've seen with some of our data monitoring systems and to support providers in making those change. Next slide. So I'm very excited for Dr. Hoffman, Jonathan Hoffman, to speak today and give you a little bit of a snapshot into how there's different ways to motivate change. And the work that is coming out of Vision 19 and the films that they're producing to really evoke thoughtful discussions and how we can really reflect on the care we're delivering and the opportunity we have to change practice. This most recent video that they produced is around suicide prevention. It actually highlights the practice of 3 clinical pharmacist practitioners, one of which happens to also be an academic detailer who's featured on this slide. And what was really exciting is just to see the passion that each one of these clinicians had about their work. And it's infectious. It's literally, when you finish watching it, it's this awe experience. Wow, I want to do that. I see why that's important. I want to think about what I could do differently in my practice to impact a veteran's life, to literally save their life, because I can be part of the solution. I can be part of the movement. So very cool new innovations that are coming out of Vision 19. I want to acknowledge their work, and you'll hear more about that. Next slide. And then finally, one of the things the VA has been focusing on is in these times that are difficult to really sustain and provide continuous quality improvement, when you don't have a lot of margin to make change in your practice, both the providers and teams are struggling with that. We think it's so important to really emphasize community and to support one another in the challenges that people are really running up against. So this has been a real focus that our team is leading for this next year, to think about ways that we can promote community within academic detailing, where we can support one another, learn together, have corporate knowledge, and to be able to progress our craft and our innovations in that manner and inspire one another. Next slide. So our national campaign for this year is substance use disorders. We've really wanted to focus on emphasizing the importance of outreach on substance use disorders. Next slide. And one of the emphasis we did was really making sure we had up-to-date resources, making sure every VISN had the ability to determine what their priority would be. A lot of great new Shark Tank ideas have come out where people are starting up syringe exchange programs. The work that we've done for OE&D has continued, but there's more work focusing on stimulant use disorder and other concerns, and having these resources available to our VISN and facility level detailers so that they can really tailor which focus and which topic they would like to progress on. Next slide. So I wanted to make sure I go through and introduce the 3 next panelists that will be speaking today. I've had the pleasure of working with Gwen on several topics and the research that they're doing. I see Jeremy is also on today. So hi, I'm so excited to see you here as well. This group has really, to me, is what it's all about. When you have research done on the intervention that you're working on, it informs you on how to be better. And I'm so very grateful that they have invested their resources and their energy into studying academic detailing in the VA and looking at ways that we can improve the type of delivery of services that we provide. It's been awesome partnering with them and seeing how our VISN detailers can even, work hands-on with this group to better understand how to support our providers and to deliver services. So Gwen Hooks is a research health specialist, science specialist at the VA Center for Clinical Management and Research in Ann Arbor, Michigan. And she's actually trained by NaRCAD. And the project that she'll be overviewing today is maintaining implementation through dynamic adaptations, and it was funded by our VA Health Administration. So this will be a great opportunity for you to hear about the projects that they're overseeing for the 4 different arms of the academic detailing interventions. Next slide. And then Jonathan Hoffman, he's currently serving as an academic detailer and the clinical pharmacist for the VA Rocky Mountain system. And I want to tell you a little bit about Jonathan, who's been working with our team for many years now, and we're so excited that he's going to present on the art of medicine, which is a project that they started on opioid dependence, and he's been working to share this information with the individuals in the field and learning from providers. And then the next slide, I want to introduce for you. This is the last presenter will be Dr. Kimberly Dickerson, who serves as an academic detailer for clinical pharmacists for Central Arkansas Veterans Healthcare System. This is for the deprescribing topic of the vital, important, optional, not indicated in every medication optimization of polypharmacy and reduction initiative. And so she'll overview with you this intervention that involves many clinical pharmacists that have been reviewing patients' medications and evaluating their efforts in order to identify safe prescribing practices across the VA system. So thank you very much for the opportunity to do these introductions, and I'll pass it back over to you, Mike.
Thank you so much. Mike, I'm going to go ahead and do the transition. So thanks very much. And Melissa, thanks for such an awesome overview. Lots of comments in the chat box about just being really impressed with your work and seeing, you know, your work is something to strive for, and also, you know, teaching us the ways that you can look at different sort of sub areas of clinical topics and be even more impactful. So thank you for those introductions. Without further ado, Gwendolyn Hooks, please take it away.
Thank you so much, Bevan and Melissa, who is hard to follow, but you all can see that we are clearly standing on the shoulders of giants. We are so fortunate to be in VA, to work with Melissa and her team, and to learn from all the great work they've done. So thank you, Melissa. Thank you, NaRCAD and Bevan. I'm going to talk a bit about the work, the research work we're doing, as Melissa talked about, sort of trying to better understand how to improve academic detailing. They're doing a fantastic job, but what can we do to make it even better? Because our goal is always continued process improvement. So you'll notice here that I have nothing to disclose, no relevant financial or non-financial relationships. Next slide.
All right, we got a poll here on a scale of 1 to 10. How important are local champions in your academic detailing work, with 10 being supremely important and 1 being, they're all right? What do we think? And feel free to use the chat box if you can't get your phone working. I'm seeing a 10, I'm seeing an 8. And the bigger the numbers get, the more that people are using them. Big 10s. I'm seeing a couple of 11s. I'm seeing a 37. Not sure what that means, but that must be pretty big. 8.35. Of course, the VA, you are so right down to the decimal point. I love it. You guys are great with the data. Give me a couple more, some 9s, some 10s, nothing below a 7. So Gwendolyn, does this surprise you? Local champions are extremely important.
No, not at all. That's the center of our work, is working with a local champion. So without that, it is very hard to do what we do. So I think Melissa gave a great overview of our program. The pieces I'll highlight here is that our work is really focused on adoption, increasing the uptake and use of evidence-based practice, but really hyper-focused on sustainment. It is one thing to get folks doing something, but to get them to continue doing it is something very different. So that's where our real focus is. We are doing this across 3 different projects, evidence-based practices to include polypharmacy, which Kimberly Dickerson is going to talk about at some point. Currently focused on cognitive behavior therapy for insomnia, which is really fascinating. And we had an anticoagulation campaign where we're really focused on optimizing these treatments across VA. And the key piece that I'm so excited about is that academic detailing, Melissa and her team are already doing that so well. The one thing we're adding is a team-based quality improvement. So trying to figure out how we can pair academic detailing with team-based QI to improve the effectiveness and really focus on some of the processes that get in the way of us using and uptaking evidence-based practices. Okay, next slide. So this is kind of the model we follow. Of course, like academic detailing services, we're theory-driven. Our focus is to make our programs really systematic and repeatable. because this is really unique to the work that we're doing as we are developing campaigns. We want to make sure that we can easily transfer that knowledge from one campaign to the next. And as I mentioned, hyper-focus on sustainability, following that biopsychosocial technical model, which really recognizes that so often knowledge is not the primary barrier or gap. There's a lot of other things that come to play, processes, cultural environments that really get in the way of uptake of interventions. And we're really focused on frontline employees, making small steps towards change. Change is hard for everyone, we know that. So if we can just get folks to commit to one small thing, then we can re-engage in the follow-up and hopefully help them to keep moving along that change cycle. So we have a 5-stage process that we follow. Really starts with information gathering, which thank you, Melissa, Academic Detailing Service. A lot of this work has been done, so we build on that. As we're developing our campaign, we look at all the other resources that are available. We have fortunate enough to have a multidisciplinary team that we depend on that helps us really hone our processes. In the communication process, we participate in role-playing with NaRCAD folks inside our team, other detailers. We actually do the detailing, and after we do the detailing, we then think about what could have happened better. We really focus on that revision process, this being an iterative cycle, that just because we did it and we made it, it doesn't mean it's perfect. There's always tweaks we can make along the way. So next slide. So really integral, you saw the poll question, integral to our work is engaging a local champion. The more engaged the champion, the better. Ideally, that champion is someone who has some autonomy, is really excited about the work, is passionate about evidence-based practices. So if you can get that, there's no limits to the work that you can do at a given site, because that is so integral. Those champions really help us understand the local framework and identifying some site-specific barriers so that when we go in and meet with providers, we understand what might come up and we can prepare. And one of the benefits really is that we have this idea of what a champion will look like and what their role is, but we really develop that in collaboration with the champion to make sure that we're not saying this is what you do, but we're allowing them room to grow in their role and make it their own. And we found that really helpful. All right, so as I mentioned this, the role of the champion is to help us improve the implementation, promote sustainability. After, we're gonna be there for a finite amount of time. After we leave, we want the process to still happen. And that's hard to do if there's no one in place locally to do that. So the champions who have influence and enthusiasm and ownership over processes really help us, like once we leave, to make sure that these, whatever incremental changes were made, are continuing throughout the cycle. Next slide. All right. So this is the key of the research we've done. These are the things that we've learned in doing this work and doing research and quality improvement, qualitative interviews. We've learned that there are so many barriers to implementation. And again, often it isn't knowledge, it is technology, comfort with technology. And the VA, we're very dashboard heavy. So providers understanding how to use and access those dashboards. Really the processes, understanding what those processes are. Unfortunately, we've paired with this team-based QI program that allows us to focus in on what the processes are, helping us understand them and improve them, and at least communicate to providers what they are so that they can understand how they get from, here's what we're doing, how do I actually make a referral to CBTI in my current system, which is so important. And we all know how important culture is. There are some sites where the culture is such that implementation is really tricky and tough. So it's important to understand that at the outset. And the universal time, no one ever has enough time to do anything, but how do we do the work in that setting? Understand that time is such a universal barrier. Next slide. So Melissa talked a bit about this, so I won't go into this in too detail, but you all know that VA is a very data-rich environment. We have access to so much data, so much innovation already happening in academic detailing service that we're able to build upon. Even still, the information that's out there, we take and made it suitable to our individual and unique needs within the MIDAS query program. Developing key messages, creating a detailer handbook, and really focusing on those barriers and facilitators and having responses to those. And also including those, we are again fortunate to have a really multidisciplinary team. We have a qualitative methodologists and analysts on board who really help, who go in before us to get the scoop, and then they can allow us to share that information with us so we're not going in blind. That's been super helpful as well, to provide that background information in advance. Next slide. So we talked a bit about this too. So very important, we do a lot of role plays within the team. Melissa mentioned Dr. Jeremy Sussman, who leads this team, is a primary care provider, which is so helpful when we're meeting with primary care providers to help us understand their struggles, their barriers, and what they need from us. Also, so we role playing with Dr. Sussman, other folks on the team, external VA practitioners and other detailers, really helping us get the messaging right. Because the message, no matter how good the message is, if the message isn't received, it isn't going to be helpful. So, and after we do that, we incorporate all those things into our detailer plan so that, again, it's systematic and can be used for the next campaign. Next slide. So our detailing looks a little bit different because it is unique to our given needs. We're in a research study, so things need to be a bit more systematic. We aim to have 2 academic detailing sessions, all of which are virtual, and we'd like to space those 6 months apart. So the initial meeting is really to introduce ourselves to providers, introduce our message, and that second visit then is designed to reinforce the message, understanding that change after you meet me for the first time and I give you wonderful information is rarely possible if it isn't reinforced. So that's our approach there. And also this piece that really is unique to us and our research needs is this fidelity assessment. It's really important to understand how you know when something is working. And the way to do that is to assess how it's happening over time. Is the way that we're delivering academic detailing, is it consistent across sessions? And when it isn't, what's the difference? What's the impact? Also, the peer review is really important, having these audio recordings of some of our sessions. So folks other than me can say, okay, Gwen, you did this here. But right here, this felt a little bit clunky. And that allows me to continue to improve over time. And obviously, it's always beneficial to have supervision outside of peers looking in at what's happening to make sure things are always going well, and when they're not, to kind of shift. So we have these things incorporated into all of our sessions, which have been so helpful for me just to continue to develop as a detailer. So this talks a bit more about the fidelity assessment. This was an internal process we created, really with this ultimate goal of continuous process improvement. We want to keep getting better. I want to keep getting better. We want to measure and be able to measure and track what's happening over time. So this isn't just what Gwen is doing, but whoever comes after me has a system in place that they can also follow. Next slide. All right, this talks a bit more about the peer review. This is a very official system in that the peers, when they review these recorded detailed sessions, and they give me individual feedback, and they provide written feedback and notes that I can go in and respond to. And as an opportunity for me to say, okay, you said this here, tell me how that relates to this particular piece. And we have a bi-weekly meeting where we have the opportunity to chat about this individual feedback, and I can respond to it and hopefully incorporate it into future detailing sessions. Next slide. So what does all this mean? So far, we've completed 2 detailing campaigns. One is polypharmacy that you're going to hear Kimberly talk a bit more about. 80% of all of our sessions were peer reviewed, which is, I think, pretty amazing. It is a heavy lift, but we are committed to doing this. 53% of all providers who are eligible, meaning that they met criteria and are at a given site, said yes to participating in the campaign, which that's the hardest piece, engaging providers. And after each detailing visit, we do ask providers to complete a brief survey. And those who completed that survey all reported high satisfaction with the detailing session. And the questions we asked are listed here. Whether or not the detailer was an effective communicator, and if the key messages are feasible to implement. And most of those reported high satisfaction, which is pretty amazing. Right. So what's to come? There is more analysis in progress. We are doing an overall analysis of VA corporate warehouse data to look at primary outcomes, which is the proportion of potentially inappropriate medications across our 3 projects. That's also a process evaluation, really looking at what it takes to get from here to there, and really digging into very specific pieces of that. We'll also have a goal of developing a training guide, and that guide goes along with our model of being really systematic. How do we get from here to there? I think on Monday we talked a bit about creating the campaign in a week. Well, having a training guide will certainly make that a lot easier because it's kind of plug and play. And that's our goal. And also we're creating an academic detailing or writing an academic detailing paper that speaks to all the processes that we follow, how they were developed, with the lessons that we learned. So that is happening, and hopefully you'll be able to see that when it's ready. We have a long ways to go, but it is happening. So ultimately, here are some key takeaways that we learned, because the goal of this being research is to learn something. And the primary thing we learned is that knowledge often is not the primary barrier. I recognize that the goal of academic detailing is to bridge the gap between what we know and what we do, but sometimes there's some processy bits in there that really get in the way of optimal care. And really, for me, maintaining a learning mindset. This isn't easy work, it's necessary, but it certainly is challenging. So focusing on, you're going to make mistakes along the way, focusing on learning, being really flexible, able to adapt to things as they come. COVID happens, and who knows what will be next. So being flexible, and relationships are so key. Working with Melissa and her team and other folks throughout the VISN and throughout the VA, like, this isn't possible if you don't build relationships. You can't get in with providers if you don't build relationships.
I love this, Gwendolyn.
Thank you.
So many nuggets. Thank you so much from all of us. A couple quick questions.
Sure.
So we have quite a few, and I know your colleague Jason is working furiously to respond. So Vishal, your answer about culture is up in the chat box. We do have a question from Paul Fanikos at Alosa. Can you give an example of an area for self-identified improvement that you worked on, if we could put you on the spot?
Oh, there's so many. I think that introductions, when you get providers in the virtual room, what is that first bit you say to them that's going to get them to engage? And I think I've worked a lot on that and got a lot of feedback about that. Like, what you say, language is so important and it matters, and really gauging even before you get to that needs assessment, which is vital. Like, understanding, how do you get the provider's attention? The first words out of your mouth when you show up in the room, what are they? So that's the piece that I'm constantly working on.
Amazing. And you really do, the humility with which you talk about, feedback and receiving, it's so refreshing. I think many detailers feel like, oh no, I got it wrong, instead of how can I get even better at this? And that seems like a subtle, sort of reframe, but it's subtle and a really important way to grow. Thank you so much. Paul says, thank you for sharing that. We have one more question, and thank you to Jason for answering Carrie and Mark's questions about the tools being validated. Actually, just Carrie's is great, because I can ask you this quick question from your VA colleague, Mark Bontavan. Curious if the survey tool is validated, and whether it might be the same one at University of Illinois at Chicago uses.
So we're talking about the post, which
Yes.
survey we're talking about? Sorry, I couldn't see the chat.
Oh, no worries. It's quite a bit up. You're blowing up in the chat. So yeah, it says surveys. Is it a survey that's been a validated tool?
The survey was created in-house and we pulled from quite a few resources, so it has not been validated.
Okay.
What's been nice about it is we're also using it aligned with some of our other implementation programs. So Laura Damshorter had her finger in a lot of pots for the stage. And so it's aligned closely with our quality improvement program that does plan, do, study, act cycles. And that made it so we couldn't use the pure academic detailing one in the first place, because you had to align the two.
Thank you, Jeremy.
Okay, that's very helpful. Thank you. Well, thank you, Jeremy and Jason, for being the ride-alongs here at the conference. And Gwendolyn, we are so delighted that you were able to join us today. Thank you for such a compelling presentation. And you've got some shout outs in the chat box that I encourage you to take a peek at. All right, up next, we have the previously introduced Jonathan Hoffman. We're gonna let you just jump right in and take us away for your presentation.
Thanks, everybody. Wonderful introduction, Melissa, and certainly some big shoes to follow, Gwendolyn, and certainly happy to be in great company with Kimberly Dickerson. I think I had a couple of polling questions. Are they on the next slide?
They are coming on up.
They're coming up. All right.
We'll get you through your disclosure. Yep.
All right, thanks. So yeah, I was just gonna, introduce myself here and note that I do not have any conflict of interest to disclose or any relevant financial or non-financial relationships. I am an academic detailer with Vision 19. We'll talk a little bit about what Vision 19 makes up, but yeah, so a couple of poll questions to start off with. Just sort of interested in some demographics of who we have here. So kind of your age group, and these are similar categories that we used in our kind of qualitative research that we did as part of kind of some follow-up on impact from our media. It's trying to categorize groups. So it looks like a decent representation, but certainly maybe more on the 45 and under group. So.
All right.
Wonderful.
And let's do another one.
Thanks for participating. Yeah, so trying to get a sense of what types of social media, commercial media everybody uses. And here we're sort of looking at what do you use most, but in the chat, if you wanted to even add some others that you use and maybe some stratification for, what you use most and second most, just to try to get a sense of how folks kind of balance their media consumption. So it looks like a large part of the audience are Instagrammers and still some
Where's TikTok? Where's the TikTok?
So
I don't use.
That would be an other.
All right. So does this surprise you, the things that are taking the lead here?
Not so much. I talking with some other, social media folks, and as we've talked across our field of other content producers, Instagram does seem to be a sort of increasing component of the market share. I am a little surprised with YouTube being as small of a user group here.
All right, and a note in the chat box that some folks use multiple and would like to put multiple, but I guess most use seems to be Instagram, which matches up with the 45 and under demographics. So let's move on to the next slide. Thanks for throwing those polls out there.
Perfect, thanks. So just to give a little perspective here, each year in the United States, we lose thousands of people from drug overdose. Some survive, but some suffer permanent injury with devastating impact to their families and friends. Our veterans who receive care at a VA medical center or community-based outpatient clinic are certainly not immune. The number of providers available to treat OUD or opioid use disorder with medications increase each year. However, there are significant barriers that remain despite available pathways to treatment. And so as one of our campaigns, we've continued to work towards raising awareness that treatment for OUD is effective and available for veterans. So as I mentioned, I'm with Vision 19, and Vision 19 encompasses a large portion of the Intermountain West, including Montana, Wyoming, Utah, Colorado, as well as Oklahoma, sort of in the more recent years. I'm based out of Utah with the Salt Lake VA and have covered territories across Montana and Wyoming, as well as Western Colorado. And the work that we're going to talk about today really involves some of the interventions that we did in Montana and Wyoming and Western Colorado. And so not so much across Utah and Colorado so far. So next slide. So the unfortunate reality among many primary care providers is that they're not ready or willing to prescribe medication for opioid use disorder. The stigma surrounding opioid use disorder often limits this opportunity for veterans to receive this evidence-based treatment. Early in my detailing career, we witnessed a powerful exchange between a few providers at a Colorado CBOC. We'd been working to improve safety of opioid prescribing among primary care providers. And part of our approach involved engaging providers in discussions surrounding the current risk of overdose in their panels. And as you might imagine, most were very guarded with their experiences surrounding opioid overdose, until one day, one brave provider shared some remorse with another provider regarding the death of a patient. When they shared the loss with the other provider, they revealed that they too had lost a couple of patients to overdose and felt alone previously in dealing with this type of negative outcome. And were thankful to learn that there was indeed another colleague, another provider in their same clinic who had dealt with or who was dealing with a similar loss. We were really surprised by the impact of this vulnerability. And I remember having a conversation saying, wouldn't this be amazing if we could just capture this and replicate it and maybe use this to create some type of spread to impact multiple providers across multiple clinics through this type of a revealing testimony. We sort of had these early dreams of recording a series of unguarded conversations, highlighting clinical practice experiences on video that could be shared across facilities and sort of draw providers together closer to embracing the management of opioid use disorder outside of a more traditional specialty SUD care setting. As fate would have it, an opportunity presented shortly after this exchange for us to travel to Los Angeles and capture some of the groundbreaking work of several emergency department providers who were starting to expand access for treatment initiation of Suboxone in the ED. These providers understood they had an important opportunity to meet the veteran where they are and deliver truly patient-centered care. Within a short time, this story about how emergency department providers in LA were expanding access to medications for OUD reached another Colorado provider who was excited about this work in the emergency department setting and wanted to know how she could expand her work to do the same in primary care. We were amazed by this impact. It was a very short piece that we had produced, but it was amazing how the media was catalyzing a commitment from a provider in another part of the country to expand access for veterans in primary care. Meeting the veteran where they are and where they feel comfortable is critical to receiving the best care. This small validation set us off on a larger project exploring what primary care providers were doing to improve care access and meet veterans where they are. Next slide. So honestly, this is a dream come true for me. Over the course of roughly 10 years during the early to mid 90s and early 2000s, I worked my way through the competitive network of student films, music videos, commercial productions in New York City. I was in Manhattan for 9/11 in 2001, and needless to say, my life, as well as many other lives, were permanently altered. I was able to reinvent my professional career, thankfully after the terrorist attacks at the World Trade Center buildings, and thankfully secured a spot in pharmacy school and eventually a role as a clinical pharmacist in Utah, where I now live. I love documentary storytelling. It's a very powerful medium that requires a lot of time and resources. It also requires a bit of magic to capture honest and vulnerable moments that communicate emotion while engaging the viewer. We put hundreds of hours into planning, recording, editing, and re-editing. While only 2 of us do the bulk of production work with 2 cameras, 5 pharmacists at the time when we produced this primary care video were on board with a single shared vision to produce a documentary about the great work that was already happening in small segments across the vision within primary care. And we hope that this then could be shared with a broader audience and begin to shift stigma surrounding opioid use disorder. Next slide. So after several long months, we finished The Art of Medicine, Opioid Dependence. And I think Anshul or some of the staff here are gonna be able to furnish a link for this video. It's an 18-minute documentary that profiles primary care providers across Vision 19 who are improving access to treatment for opioid use disorder. It aims to facilitate positive attitudes and reduce negative beliefs towards patients with opioid use disorder. So this is Dr. Christina Gallup. She's a phenomenal professional, a powerful woman, and a featured, I don't want to call her a character, but she is a character if anybody on the call here has met her. She's featured a number of times in the film as a practicing physician at the Salt Lake VA, and she's a strong proponent for framing substance use disorder as the primary problem for her primary care patients who receive care for any use disorder. Next slide. There's a ton of discussion around who should be treating opioid use disorder and where the treatment should be initiated. The reluctance to treat often manifests as stigma that limits patients' disclosure of substance use disorder, as well as efforts to seek treatment. As you may imagine, as fewer patients reveal their substance use, the patient-provider relationship is impaired, and fewer individuals seek treatment. This, when combined with limited professional knowledge, prevents a thorough assessment and a diagnosis of SUD, or substance use disorder, including opioid use disorder. These missed opportunities to address a patient's primary problem can lead to increased morbidity and mortality. There's a large and expanding body of primary literature supporting connections between abuse, between substance abuse, stigma, and undesirable health outcomes. There's also significant evidence supporting the impact of masked health problems on increased primary care touchpoints, fragmented care, as well as frequent emergency department visits. So this is a critical moment in time, I think, to continue to capture opportunities to influence practice. Next slide, please. The short film format in and of itself draws providers into familiar clinical practice settings to help staff identify with colleagues like Kim Bayless and Anna Holtai, you see here from Salt Lake, and Kim Snyder from Montana, all of whom have expanded their practice and challenged some of the personal and professional stigma surrounding treatment of OUD. With the help of Dr. Martha Duffy, a physician who's on the call. Martha, thank you a ton. At the time, she was an interprofessional advanced addiction fellow from the Boston VA. With her guidance and input, we developed a quasi-experimental pre-post design using a modified 15-item questionnaire called the Opening Minds Stigma Scale for Healthcare Providers questionnaire. The tool was adapted for SUD and to examine providers' attitudes towards individuals with opioid use disorder. The scale is a traditional Likert scale with a series of balanced response values ranging from strongly agree to strongly disagree. And each item is assigned a score from 1 to 5. And using that scoring system, we're able to measure shifts in stigmatizing attitudes. Next slide. So 86 mental health and primary care providers with varying degrees of experience managing opioid use disorder attended one of 8, we'll call them red carpet screenings of our short film, Art of Medicine, Opioid Dependence. We had all sorts of hopes and aspirations to have the stars from our film roll up in limousines and walk the red carpet to the premieres at each of the 4 clinics. Unfortunately, reality set in, and we had to settle with 60-minute meetings during people's busy work days. Everyone was asked to complete the pre-test questionnaire before viewing the short film, but all were allowed to watch the short film regardless of whether they completed the test, the pre-test or not. We engaged in some discussions after the film screenings. However, the majority of conversations that ensued occurred more as traditional one-on-one academic detailing visits a few weeks later. Next slide. So the changes in the Opening Minds Stigma Scale for healthcare provider scores before and after the intervention showed a small but meaningful effect. So we have some confidence that the intervention may have a significant impact on shifting stigma surrounding challenging practice decisions. So of the 4 questions that targeted disclosure, we had a significant change in 3 out of those 4 questions towards less stigmatizing beliefs. Of the 5 questions that targeted social distance, we had a significant change in 3 of the 5 questions towards less stigmatizing beliefs. And of the 6 questions that targeted attitude, we had a change in half of those questions towards less stigmatizing attitudes. Next slide. So during my one-on-one follow-up visits in the weeks following the film screenings of The Art of Medicine, most providers were really excited to share their impressions about the screening experience and how the film made them feel. I really felt this offered a unique social currency beyond the traditional discussions surrounding primary literature and personal clinical anecdotes that often enhance practice change. There's certainly instances where the media on its own can impact practice. However, we envision this to be used as an element as part of a campaign's communication plan. The viewing of the film and sharing the experience with a clinic among providers and staff can catalyze discussion and offer very meaningful pathways to build confidence for practice expansion. Next slide. Our media can be edited to suit a wide range of applications that supplement staff meetings, enhance academic detailing follow-up, and reinforce health system commitment to patient care. We continue to explore how best to structure the communication plans for our campaigns, with our most recent offering continuing the Art of Medicine series. As Dr. Christopher mentioned, we explore some of the work of pharmacists in preventing suicide. This is the second project in this series, and with that, we've added some shorter versions, some teasers, 1 and 2.5 minute segments of the media to help with some of the challenges that we've encountered with staff finding enough time during a busy workday to watch a 17 or an 18-minute film. Ideally, we'd like to spread this insight of providers like Dr. Joe Frank, you see up in the upper left, and Dr. Fatima Brentes Pais on the lower right. We'd love to share their impact through social media like Instagram, and LinkedIn, and Twitter, with a broader goal of supporting a community of professionals that reflect the compassionate, dedicated individuals who make up each facility and clinic, and most of whom, or many of whom, work remotely. This steers the typical perception of medical centers and CBOCs as nameless, faceless buildings to one that is a caring and healing environment made up of dedicated professionals. Next slide. Oops. Our work would absolutely not be possible without the providers who volunteered to share their firsthand experiences with managing patients with opioid use disorder. We're also incredibly grateful for the collaboration of our entire Visit 19 academic detailing team for the support and commitment to our mission. The interest we've received across the country from other detailing programs, from other practicing providers, in developing impactful media that catalyzes thought and shifts stigma is truly impressive. It's wonderfully reassuring to have like-minded professionals across varied disciplines engaging in the growth and development of this innovative application of modern communication tools. So next slide. So I wonder, what is our impact? How many of you are interested in learning more about how to leverage media to drive the impact of academic detailing?
If you want to know more, A. If you don't know, if you're unsure, maybe you'd like to try it, it's a C. All right. Well, we got some yeses or unshures. No no's yet. So you did a good job selling it.
I love it. There's definitely some I think question as we've started to share this with the field about how to use it. And so that's, I think, coming next year. We'll be back with some more details about exactly what the formula for success is going to look like.
Wonderful. And we will partner with you to be in person and perhaps have a black tie event over a red carpet in the style of maybe Mariah Carey or some other pop stars. You can make demands. We'll see if our grants can get those met. And thank you so much. So we're running a little behind on time. We did get to have a poll. I know we have a question or two here. Jonathan, if you don't mind responding to those in the chat, that would be great. But just so folks monitoring the chat know what's come up in the chat, we have two questions. One is a yes, no, so maybe we can put you on the spot for a second, Jonathan. Carrie Meyer wants to know, has there been cross communication with other VA healthcare systems about this approach?
Yeah, I mean, there are a number of others, VA facilities that are using media to impact academic detailing. I would say that the media that I know about is probably not in the same vein of sort of a documentary storytelling. The media that I know about is probably more educational, maybe a little bit more technical, rather than focused on sort of behavior change and trying to drive away some of the barriers like stigma that may get in the way of practice change. But nonetheless, I think still, very innovative approaches to, sharing information and trying to drive change.
Excellent. And our last question from Dr. Fisher. Mike, I'm going to put you on hold and have Jonathan answer in the chat box about whether video resources like these need to be customized for different groups and perspectives. I'm going to guess the answer is yes, but if you can sound off on a little more detail, Jonathan, we'd be grateful. Thanks so much for a really innovative approach and a really new type of presentation here at the conference. We appreciate you. All right, Kimberly Dickinson, take it away for our final presentation before lunch. And again, I mentioned in the chat box, we are running behind, but please do stick around for an additional 5 to 10 minutes.
All right, no pressure. I'm hearing I'm the last thing between everyone and their lunch. So I will make sure, I hope that the time is spent well. So I want to thank you for the opportunity to present today. And again, I'm Kimberly Dickerson. I want to thank Melissa Christopher, also Dana Wells, who's on the call for the work that we've done on Vion within VA. And so I appreciate, again, the opportunity to speak to you today about this polypharmacy initiative. So there are no conflicts of interest. I am currently employed by the Central Arkansas Veterans Healthcare System, where the program was initially implemented.
All right, we're going to kick off with a poll. Over to your phones. Has your detailing program ever worked on a polypharmacy campaign? We got a yes, a proud yes, no, or perhaps not yet, unsure. Perhaps those are for folks who don't know what polypharmacy is. And I know you're going to walk us through that in just a few moments. So we've got an interesting sort of neck and neck yes and no, only about 8 to 10%, well, now 12 of yes ahead of no. So let's dive into the work you've done, what polypharmacy is. Thanks so much.
Thank you. So we'll just quickly go through Vion as a medication deprescribing methodology, and we'll talk about our journey from ideas to action. We'll provide a crosswalk between Vion and how it helps to meet high reliability organization concepts. Talk about our challenges, Vion data, and next steps. And so our Vion team is fairly multidisciplinary. We do enjoy a great relationship with Dr. Sarah Bitar, who is the champion of the methodology, if you will. She's our thought leader. Also, several other pharmacy informaticists, so Christopher Sedgwick and Ashley Wallace-Lacey, help us greatly with our data and informatics, prospective and retrospective population health management tools. We also have Laverne Esters and Melba Hobbs, who are RNs. So, it's helpful to have a multidisciplinary approach as you're sort of embarking upon a campaign like this. And so we also enjoy a relationship with the Diffusion of Excellence Office. Vion was won VA Shark Tank in 2016, and then went on to be approved for national dissemination or diffusion in 2018 through Diffusion of Excellence. And so we appreciate the opportunity to work alongside them to help us diffuse the practice. Next slide. So what is Vion? Vion is an acronym that can be used or applied to medication lists when a provider is completing their medication management or review. The V for Vion stands for vital or life-saving. I, important for quality of life. O, optional. N, not indicated or treatment complete. And E is that final check to make sure that every medication actually has an indication. We do believe that Vion contributes to HRO concepts, and we'll talk about that here in just a moment. So what is the problem that we're trying to combat? We believe that polypharmacy is an ever-increasing problem across most populations, to include, of course, our veteran population. But there is not one way that polypharmacy has been defined. And so, nor are there any universally applied tools used to combat polypharmacy. And so we wanted to help create something in that space to help providers with combating polypharmacy that could be utilized at their fingertips within the electronic health record. Next slide. And so at the outset, defining polypharmacy also proved to be sort of difficult because there again is not one industry standard as to how polypharmacy is defined. So of course it can be defined as anyone taking any one medication more than what they actually need. And then depending on where the patient is being seen, whether it be primary care, whether they're a CLC patient, it sort of depends on the priority of the area as to what or how polypharmacy is being defined. And so we've taken a step to define polypharmacy as the continued taking of potentially inappropriate medications versus try to assign a number of medications in particular. Next slide. And so, again, we won Shark Tank in 2016, slated for national diffusion in 2018. And in 2019, November of 2019, for FY20, VION became a national academic detailing campaign. Within the AD SharePoint, all of our education materials for providers for sites that would like to get started on implementing VION, in addition to those tools that would be used by our academic detailers, be it those prospective population health management tools that they want to point other clinical pharmacy practitioners to, or providers, or provider panels, so patients that the providers may want to pinpoint. All of that information is housed within the National Academic Detailing SharePoint. Next slide. So our key messages: before renewing a medication, consider the potential risks or need for continuation or duration of therapy. If there are clinical signs of non-adherence or adverse effects, consider simplifying the medication regimen. And some strategies for simplifying may include tapering, combining where appropriate, or deprescribing. And VION, we believe, also helps to address medications in the Institute of Healthcare Improvement's age-friendly movement. It's actually been accepted through our geriatrics and extended care office that VION can be used as a mechanism to address this, and specifically looking at the 4 M's and what matters to the patient: mentation, mobility, and medications. Next slide. And this is our national footprint. VION, again, was started in 2016, and we've really enjoyed the opportunity to diffuse this practice across VA. Just to orient you to this footprint, so there are sites that are basically just getting up and running, so they may have impacted up to about 50 patients, and then sites that we consider promising practices that have impacted between 450 and 499 patients, all the way up to our gold status practices that have impacted over 10,000 patients. So when we look at this, what I've found really important to take a second look at is how academic detailing has helped to sort of frame where you see the greater number of veterans being impacted by the polypharmacy methodology. And we do have a standout VISN that are also included on the call today, our VISN 19 team that did approach implementing VION and used academic detailing to help talk to providers about addressing polypharmacy. And they, of course, are the VISN that has impacted overwhelmingly, the most veterans with this initiative. So VION, we believe, also really aligns with the concepts of high reliability organizations. And this is just a crosswalk that sort of indicates how VION helps to improve leadership's commitment to improving patient safety. Again, creating a culture, a safety culture, where we hope that we're able to decrease the risk of patient harm. And of course, we also apply continuous process improvement as we hope the field is able to see, and that we continue to provide different iterations of our dashboards that have updates from the field and subject matter experts that are included. And as well, we make sure to include the latest information coming from primary literature as well. Next slide. We do have some key partners outlined here. We really appreciate all of the effort from the Academic Detailing Program Office, the GREC, Sage Query, and Base Query that we'll talk about a little bit later, as well as Midas Query, and then the Diffusion of Excellence Office. Next slide. So back in 2019 and 2020, the American Society of Consultant Pharmacists listed VION as a VA agency process, and we felt like that was very important in sort of getting the word out about how VA was working to combat polypharmacy. And in addition, the Loan Institute also included VION in its Eliminating Medication Overload National Action Plan in 2020. So these documents, if you will, are the opportunity to sort of be placed in a situation where VION as a methodology was being recognized by these institutions, also helped propel the methodology within VA as we were having conversations with providers and stakeholders that had a say into whether or not the initiative was pushed forward nationally. Next slide. VION also recently partnered with the Sustainable Medicines Partnership, which is an organization out of the UK that works to look at how the environmental impacts, if you will, of polypharmacy and medication use, and help to sort of, provide a carbon footprint of what it looks like as medications are being disposed of. And so we appreciate the opportunity to work with them to sort of see how we can combat polypharmacy from a different mechanism, if you will. So if the patients aren't necessarily being prescribed potentially inappropriate medications, maybe there'll be a lessened impact on the environment. Next slide. So this week, and as I speak, most of my VION team and colleagues are actually in Dubai, where they're there to present VION as a patient safety initiative. We are really excited about the opportunity to present this there. I really miss having the opportunity to go. Dr. Bittar was also listed as a finalist for the OSCO Excellence Award and will be presented there, hopefully with the Gold Award that just outlines the work that we're doing to improve patient safety and quality around polypharmacy throughout VA. Next slide. In terms of national data, so as Gwen said earlier, the VA has a host of data. So we're very data-rich entity. And within that data, we have the ability to get pretty granular with what we're able to see about patients. And so as you're actually documenting VION, we have included VION discontinuation order reasons within CPRS. And those reasons we're able to sort of look back to see how they're being utilized as VION is applied. And so as you can see from this slide, over 40% of patients, or over 40%, excuse me, of the medications being deprescribed are being deprescribed using a reason that the patient was no longer taking it. So they reported that they're not taking the medication, hence the medication was being discontinued. Second to that is that an alternate medication is being prescribed. And so if the patient actually requires a medication for their particular diagnosis, but the medication that they're taking is potentially inappropriate, we're also able to capture that information. Next slide. In addition, our data tools, and so we have both retrospective and prospective data tools available. So the retrospective data tools include our discontinuations and implementation dashboards, and sites are able to sort of do a look back to see how they're going, or how things are going with their implementation using those. We also have prospective population health management tools, and that would include the VION risk dashboards and the VION PIM dashboards. These are the dashboards that would be used by our academic detailers to create more provider-driven reports that would identify who those priority providers are and who those patients are that could potentially be impacted by implementing or applying the methodology. Next slide. And so Gwen spoke earlier about the work that's being done with MIDAS Query. And so we are really excited about some of the outcomes as we consider the barriers to implementing Vion. We found that there, of course, as a new methodology, we had not really had any real review that was independent of our team of the methodology itself. But the VA did work to put together a synthesis document that was essentially a meta-analysis of all of the documents or primary literature out there related to polypharmacy. And so with that, we felt like it was appropriate, again, to work with our stakeholders to determine the best way forward as it pertained to evidence around the methodology. And so what we found through MIDAS Query, their first report to us was that Vion was reaching patients who were older with more comorbidities. And so that was really good information. We wanted to make sure that we actually were reaching appropriate patients. Next slide. They also found that in clinics where Vion had been implemented by the clinical pharmacy practitioners, that there was a slight but statistically significant decrease in the use of Beer's medications in those patients. Next slide. And lastly, in addition, for those patients that had had a documented review, they found that they were less likely to have a hospital admission or a need to be seen in the ED during that 6 months period after their initial review. So this is all really promising information. We do have another evaluation that's going to be more broad and more specific as it relates to application of the methodology and outcomes related to cardiovascular, neurological, and other concerns that have been brought up along the way as it pertains to just needing that evidence base to really, really get behind the methodology. Next slide. And so we have had a lot of comments from veterans and clinicians alike around Vion. From veterans, we heard a lot about how they were appreciative of the review, making sure that they were actually taking medications that they felt were helping and not harming. And from clinicians, they appreciated an opportunity to be able to address polypharmacy in a way that would point them to those most potentially inappropriate medications. And so it's been easily adopted across the majority of sites across the VA. We have a few more sites to go, and our hope is to continue to diffuse the practice. Next slide. So for next steps, again, we are awaiting additional outcomes from the VACE query evaluation, and that's the VA Center for Evaluation. Those outcomes we hope to see in 2024. And we'd be happy to share any additional information as it relates to those outcomes with this group at that time.
Amazing. Thank you, Kimberly. We really appreciate this. What an amazing selection of different programs, diverse programs, and wonderful speakers from the VA. I'm going to stop the share so that people have a moment to see each other. Please forgive us here at NaRCAD for jam packing with too many delightful presentations today, and being a little more ambitious than perhaps we might have, but I wouldn't undo it because we've had the chance to chat with so many folks. A couple questions for Kimberly. If you want to shut your cameras off and munch on your lunch while we wrap up this final session. Thanks, Kimberly, for being patient with us. So I have a great question here from Melissa. Kimberly, there's so much medication safety improvements going on here with deprescribing strategies, safe instructions on how to deprescribe, coming from the partnered work with clinical pharmacist practitioners. One area that Melissa is saying that she doesn't think is often discussed is the impact this can have on veterans not paying for unneeded copays as well. Many patients have copays for their prescriptions. Being able to reduce that financial burden while addressing safety is really helpful. Has your group been able to calculate that impact, positive impact of savings for veterans? It looks like yes.
So, well, actually, we have not taken that second look, but I do agree 100% that that's really important. Oftentimes, you'll see patients, especially outside the VA, that maybe are not taking all the medications that they need because they can't afford them. Within VA, if a medication is actually ordered by a provider, the patient really has no say as to whether or not, or very little say as to whether or not that medication is going to be sent. We do have some upcoming changes that'll be great, that can help some with that. But with that being said, I agree 100% that this is something that's very important to take a look at. Our financial, if you will, outcomes are more so looking back at the actual drug cost for those medications that have been deprescribed using the methodology, and they do not factor in at all any savings for the veteran.
Excellent. Thank you for sharing that. We have one last question before we rock and roll. Elizabeth Fallymuck says, as a hospitalist, I see so many patients being started on unnecessary meds that just get continued at discharge. Is the Viome program integrated with hospital follow-ups, particularly if these folks are admitted to a non-VA hospital? Great question.
That is an awesome question. So I think within VA, if medications are deprescribed, we are definitely doing follow-ups. The model at our VA in Little Rock is that if a patient is discharged and they are enrolled in our Geri-Packed setting, then from that discharge, from that ED visit or acute care visit, they are followed up more quickly. And that is our Viome dashboard is used in that process. Outside VA, where we're looking at community care, I've not seen that precedent at all, but I agree that it would be really helpful to patients and improve their care if there were such a follow-up sort of created, where there was some hand-holding, if you will, from the outside, if you will, outside VA to within.
Awesome. Thank you, Kimberly. We are so grateful to Melissa, Gwendolyn, Kimberly, and Jonathan for really showing us such a diverse slice of programs across the VHA. Thank you so much. It's time to rock and roll for lunch, and we will see you in 1/2 hour at 1:15. Anna, what's going to be happening then?
Yes, we are going to hear from our yearbook presenters. So we'll hear from 3 fabulous programs who are excited to share their successes from 2022. And we'll also have time for all of you to share in the chat your successes and do some shout outs. So if you don't mind staying logged into this Zoom link, just turn your audio and video off. That way, when we get back from break at 1:15 p.m. Eastern, we can start right back up with our presentations. And if you'd like to continue the conversation in the chat, please do so, but please also take a break for yourselves. We will see you back here in a 1/2 hour. Take care. Thank you all so much.